Okay. Good evening. Good evening. Good evening. Welcome to Fertility Talk. So those of you who was on a couple of minutes ago with me, so Doc is ready to join us now. Thanks for coming back, guys. Thank you. Just gonna wait for everyone to get the notification that we are back. Okay, so we're back. Doc's ready, and she should join us now in a couple of minutes. And yeah, so tonight we're talking, like, I just want to mention again, we are talking to Dr. Tebogo Deo from the Genesis Reproductive Centre. And I'm just going to wait for, Doc, you ready? Are you there? If you can just please send me a invite so that I can accept you. We're talking PCOS and OHSS, which is Ovarian Hyperstimulation Syndrome. For those who are doing any sort of IVF treatment, fertility treatment, and you're dealing with PCOS, you would know that there is quite a bit of chance for you to actually to suffer from this if you're not careful. And but let's wait for Dr. Tebogo. She's the director at Genesis Fertility Clinic. There she goes. Nice to see you here. So I've just sent Doc an invite. There we go.
Hello.
Hi, Doc. How are you?
I'm good. How are you? And happy
Good,
heritage.
thank you.
Happy heritage.
Sorry?
Happy heritage.
Oh, happy Heritage Month to you too. You look great today.
Thank you.
Okay, so I was just telling everyone, so Dr. Tebogo is a fertility specialist and also director at Genesis Reproductive Centre, which is out in Pretoria. It's always great having you here. I know you do another talk as well on Wednesday evenings, so we were giving you a couple of minutes for that.
Yeah, thank you.
Yeah, so there's quite a few people from overseas as well that's joined us, and I was trying to explain to them what load shedding is, because my electricity went on just at 8 o'clock. I was just hoping it just goes on. So I hope you've had yours for the day.
Yeah, we're good.
Okay.
We're good. Yes.
Okay, so we're all good. So we're talking, it's the month of PCOS Awareness Month. It's PCOS Awareness Month, September. And this is our last of the month with regards to PCOS. And I hope that everyone went through this month of talks with all the specialists, that you've actually learned something and applied a few things as well. And if there's anything, always, Doc is available. You can always email me, or you can ask the questions put it in the comment section, and we can ask Doc. She's very, very clued up, and I always watch her status of where she's been and all these conferences and stuff. So yeah, so thanks very much for joining us, Doc. It's always a pleasure having you here. And like I said, we're going to talk about ovarian hyperstimulation.
Yes.
So before we start with that, I think I know there's a question we always ask at the beginning of this whole month is, what is PCOS? But we also have to remember there are lots of women on here that doesn't even know they suffer from PCOS. I don't know what it is. So if you could just first explain to the women out there what PCOS is, and before you actually get into, the hyperstimulation syndrome.
Okay, polycystic ovarian syndrome is quite a common condition that affects women, and mainly it is seen in reproductive age. Usually symptomatology will be menstrual disorders, and most of the time it manifests as very few periods, so we call it amenorrhea. So you get prolonged periods of not having seeing your period, which means that you are not ovulating, and then it is associated with increased androgen, which is male hormones, and this will manifest in the form of acne. It may be unwanted hair growth, so hirsutism in the chin, around the nipples, and in non-gynecological areas may also manifest as balding. And then it may be also associated with, because it's a syndrome, with hyperinsulin, which will present as what we call acanthosis nigricans. That means very dark neck that you see.
Yeah.
it is associated sometimes with metabolic syndrome, which will be seen by increased girth, like the abdominal circumference is bigger, so a person will have a bigger tummy, high blood pressure, high cholesterol, and it may be associated with infertility as well.
Yeah. Okay. So if you could maybe just go through what OHSS is, and who would be over susceptible to it, or what happens when you actually get this.
So, ovarian hyperstimulation syndrome is a complication of hyperstimulation that usually occurs during ovarian stimulation, and we do ovarian stimulation associated with the intrauterine sperm, what we call IUI, or we can do it for IVF. So even people who are taking something that is supposedly as benign as clomiphene citrate or Fetomid, which is usually what the brand name that is available is. So just taking Clomid from the GP for that matter, unmonitored, this person may produce too many follicles and then they develop a hyperstimulation syndrome. But usually we see it particularly with people with polycystic ovarian syndrome or PCO, meaning that they have a lot of follicles in their ovaries, and during hyperstimulation or superovulation, when you are giving this medication for ovulation induction, especially for IVF, you can make too many eggs, and then you will then present with too many eggs. More than 20 eggs can be very worrying, and a person will then usually present with bloatedness, very increased fluid in the tummy. This fluid can go on to fluid in the chest as well, and because of the fact that you have this like leaking blood vessels, it's associated with very elevated estrogen level, and as a result of that, it gives this hypercoagulable state. So your blood clots very easily, and you can develop deep venous thrombosis. And I mean, in its mild form, it will be just like a discomfort, and in its severe form, you may end up in ICU.
Wow. Okay.
Mm.
So what would you do in a case like this when somebody is prone to it almost, or you've done one treatment and this happened and the person developed OHS? What would you then do
Okay,
for the
so
next one?
first, we must identify the people who are at risk. This is why we would do like AMH, a blood test for AMH, and at levels, especially more than 2, we start worrying that there's a chance that you will hyperstimulate. And we also do the follicle count to be able to determine how many resting follicles are there that are likely to be to develop, such that then you can have hyperstimulation. And then based on this, then we will control the dose of the drugs that we will give you. And we'll give a cycle that does not include agonist. So what we used to call Lucrine, now you have different forms of it, Luprolide, because we will use this as a trigger drug instead of your normal orbital drug. So usually you will use an antagonist cycle, so that should you have made this many eggs, then you can use Lucrine to trigger. And the reason is because Lucrine will only be in your system for about 48 hours or so, a short period of time. It's got a short half-life, whereas Orbitrol can be in your system for up to 7 days. So because of this, we want your body to be able to recover without this drug staying in your system for long. And then one other system is that a thing that we do is that we split your cycle. We do what we call freeze all cycle, because we know that sustained pregnancy, the beta HCG of pregnancy, may also make the condition to be worse. So we then will freeze all, so that you obviously don't fall pregnant, and as a result of that, it is much easier for us to treat it should that be a condition. And one of the reasons also why we freeze is because triggering with Lucrine renders the endometrium not to be stable enough to sustain a pregnancy. That's why After we've triggered with Lucrine, we will take out the eggs, and then we will just allow you to rest, or your body to rest, so before we transfer in the next cycle.
Okay. Well, you said something about miscarriages. You know, is it PCOS that causes you that you could have an increased chance of having miscarriages? Is it
Yes.
the PCOS itself? Okay.
Yeah, PCO itself can put a person prone to miscarriage. But if you had triggered with Lucrine, your chances actually are most likely to get a failed cycle more than miscarriage, because your endometrium is not sustained enough that it will be able to carry this pregnancy, unless we give small doses of Ovitrel in between. But this is not worth it to take this risk. And as a result, because we now know the dose that we can give, the trigger methods, we look at the at-risk person, it is fairly not as common anymore that we are
Yeah.
seeing. But should it happen, or rather, should a person be like this, it is something that is known. We will have informed the client that is coming in for fertility treatment, and it's quite a devastating complication to have.
Yeah. So it's actually something that I had a conversation with someone this morning. She called me, and I thought I have to ask you this question. So
Mm,
this lady's 46 years old.
mm.
She's just been diagnosed. She doesn't have any kids. She's just been diagnosed with PCOS. In someone that is 46 years old, what would you suggest? Where do they start? You know, even if they being able to come and see a fertility specialist isn't their first option, or they're not able to, what would their first choice be? What should they do first?
Obviously, I
What are
mean,
the options?
uh,
Sorry.
yeah, lifestyle changes is quite important.
Yeah. Sorry, I think
You have,
here we go.
can you, yeah, you
Yes, I
can
can
hear
hear
me.
you.
Okay. Yeah. So the one thing about PCOS is that you struggle with weight. So we will always talk about weight loss. It's quite important. Weight loss. It is difficult to lose weight for people who have got polycystic ovarian syndrome. So you must consider seeing a dietitian, healthy diet, healthy lifestyle, like reducing your sugar intake and all that, and eating healthy, alcohol intake, stopping smoking, exercises, absolutely important. And so these are some of the things that the person must look at. A person who's 46 years old, I'm sure we are now just looking at health more than fertility there. And the
Yes.
main thing being looking at the metabolic syndrome. So metabolic syndrome includes high cholesterol, includes high blood pressure, and a high BMI that puts a person at risk of diabetes as well. And as a result of this, and these are quite, you can end up with a life-threatening condition. With hypercholesterol, you may now end up with angina or stuff like that. So the important thing would be to go and check these and make sure that they are in control, because it's no more just about fertility, but it's also about your health and morbidity for your health as well.
Yeah. At Genesis, Doctor, what is your cutoff for an age cutoff, basically, for someone that's trying to conceive? Do you have a cutoff age, or is it all to do with the person's health?
Person's health, and we go up to the age of menopause, and the average age of menopause is 52. But bearing in mind that most people after the age of 40, your chance of miscarriage goes to 50%, and your fertility reduces quite remarkably. And because of that, then we will go on and screen to see whether it is possible to use your own eggs. Otherwise, beyond 40, most of the time, the success rate goes up to 80% using donor eggs, because then the donors are much younger. So people up to the age of 52, we probably will be using a donor eggs, but making sure that you are healthy and it is safe for you to carry the pregnancy.
Okay. I've got my last question. If there's anyone else who's got questions, please put it in the comment section. But what is your first, at Genesis, what is your first sort of treatment or what is it the first type of thing that you would do to someone that has come in that is being diagnosed with PCOS, and irrelevant of the age or anything like that? What is the first thing you would do or ask that or request from that person?
So obviously, I mean, polycystic ovarian syndrome is a syndrome, and you would be looking at what is it that the person is looking for. So as I've mentioned, one of the problems could be infertility. So obviously, if it is infertility, we'll be checking are your tubes fine and all that. And if that is the case, we may just be doing ovulation induction and then artificial insemination. If then go on to IVF, depending on what is necessary, how do your sperms look like. Some people may just be presenting with amenorrhea, and the problem with prolonged period of not seeing your period is that the lining is building up, and as the lining builds up and you are not shedding, you run a risk of having hyperplasia, which is like a pre-cancer lesion of the womb. So we must make sure that you see your period at least 4 times a year. So if you
Yeah.
see your periods every 3 months, that would be good. And then the other things would be like your hyperandrogenism, which is the increased male hormones, and these ones are now usually presenting with acne. They are presenting with unwanted hair growth, and some of them are struggling with weight loss. So obviously, the treatment of a person who has got polycystic ovarian syndrome will depend on what is the problem that they're presenting with.
Yeah, I like to mention what one of the doctors said on one of our talks, is that with PCOS, they like seeing someone with PCOS, and I like to tell the women this because the ladies that's dealing with PCOS, it's one of the easiest things to deal with when it comes to on the fertility specialist side to help them conceive. So just basically saying to the women out there that there is hope, is when you've been PCOS is not a life sentence in sense of you're never going to have conceived. There is something that they can do if they take the correct steps and go and see a fertility specialist or a gynae for that matter. Am I correct, doctor?
Absolutely correct. I always tell young people that are diagnosed with polycystic ovarian syndrome that that's actually a blessing in disguise. Instead of waiting for long trying to fall pregnant, within 6 months, if you're not falling pregnant, come immediately. If you know that you are having this prolonged period of not ovulating, then rather come and see the fertility specialist so that we can help quicker. And indeed, as much as some people may have a resistant polycystic ovarian syndrome, that it is difficult to induce ovulation. But ultimately, there's quite a few things that we can do. And of all the causes of infertility, indeed, it is one of the easiest, and there is hope, and usually success rate is quite good.
Awesome. We've got one question here is, I had 2 failed ovulation inductions. My gynae never said I had PCOS, just cysts. But have all symptoms. Going to a new gynae for a better opinion. What would be the first steps in dealing with PCOS?
So if we are talking about ovulation induction in particular, obviously the first thing, I mean, we would have to check whether the person has got high BMI or it's a lean PCOS. So if you've got high BMI, the first step would be to lose weight. And we found that even just losing 5 kilograms has helped people so remarkably. Just by losing
Yeah.
weight, their cycles actually improve, and they may even fall pregnant spontaneously without us doing anything. So that would be one thing to do. And then after that, if we are looking at ovulation induction, then we obviously will go on a stepwise method, starting with the pills and then moving on to injections. I've had clients that have gone on up to day 21, day 23, while you are inducing ovulation before they actually ovulate. So that's the one thing, that if you have polycystic ovarian syndrome, the cycle may not be like an average person where they would expect to be ovulating by day 12 to day 14. So we just continue on and on monitoring the follicle tracking and see, and we may even have to stepwise increase the dose that you are taking. We usually increase on a 7-day basis, and the success rate is quite good.
Awesome. Thank you very much. Thank you, doctor, for taking the time and doing this talk. I don't know if you have any closing remarks, and if you could just give your details of how they can contact you.
Okay, thank you very much for having me, Lee, and on this show, and I hope that we have been able to shed some light with OHSS in particular. It is, as much as it's a life-threatening condition, it is quite easy to treat. Most people are treated on an outpatient basis, and if after you have had your treatment, I mean, something as simple as ovulation induction, you started having bloatedness, you start having nausea, vomiting. We usually encourage our clients to weigh themselves every day. If you are gaining like a kilogram a day, that's something that you should start worrying about. Drink lots of fluids, lots of fluids, lots of fluid. It helps. Otherwise, contact your doctor. Where can you find me? I'm based in Genesis Reproductive Centre. It is in Triumph Hospital, which is in Pretoria. And you can get hold of me by sending an email to reception at Dr. Deo, which is drdeo.co.za, or else you just call us at 012-367-4364. And we will be able to assist you further if there are any other questions that we've asked, you wanted to ask, and we haven't been able to help.
Okay, awesome. Thank you very much, Doctor. Have a great evening and see you soon.
Thank you, Leanne, and have a lovely evening.
Thank you. Thanks, guys. And that's Dr. Deo from Genesis Reproductive Centre. So again, if any of you have any questions for Doctor, you can contact her directly. You can also come, Genesis has a full page on our website, and you'll have all the details on there. They're also on social media, on Instagram, and you can follow them at Genesis Reproductive Centre. And you will also find their details on our Instagram as well. So thank you everyone for joining us this evening, and all the best. Thanks. Bye.
Goodbye.
Bye.